Welcome to Is Your Liver Healthy? I'm your host and Vice President at the Global Liver Institute, Jeff McIntyre. So if you're listening to this podcast, chances are you have been impacted by cancer at some point in your life, whether individually or, well, by someone you know or care about. It's considered one of the more intimidating diagnoses that a person can get. Yet there's so much about it we don't understand. Combine that with a lack of awareness of liver health, and there's a recipe for a lot of work to be done. October at GLI is our annual Liver Cancer Awareness Month. It's called October for Livers, and you begin to see a little more liver health awareness coming out around this as well. So on this episode of Is Your Liver Healthy, we dive into Liver Cancer 101. What is it? What's unique about it? How does it happen? And what are the next steps when something pops up during a screening? Joining me today is Dr. Neehar Parikh from the University of Michigan's Department of Internal Medicine, Division of Gastroenterology, to talk about all things liver cancer. Let's get started. All right, joining us today, Dr. Parikh from the University of Michigan. Thanks for joining us. I want to get started here talking a little bit about your background, Dr. Parikh. I know you've got a couple of different things going in as you see patients. You're a transplant hepatologist as well. Tell us a little bit about what your day and what your life is. What do you do in Michigan?
Yeah, I'm a transplant hepatologist, as you mentioned here, but I wear a lot of different hats. I've been here for 12 years now, and during that time, most of my time has been directing our liver tumor program, which is a multidisciplinary program. That's one of the longest standing programs in the U.S. that where we have multiple types of providers that see patients with liver cancer. I also spend time in the transplant clinics, doing evaluations primarily on patients who are eligible for liver transplant with liver cancer. And then, I also have some administrative roles as the director of the hepatology program here, and kind of manage our group, which is, quite large.
That's a lot. So without going too far in the weeds, I want to go back to a very, very basic question. This may even be a prereq for Liver 101. I think when we think of cancer writ large, people think about tumors specifically. I'm wondering if you can help us as patients listen to this show. What is liver cancer? We think of it, as fibrosis that turns into cirrhosis in more kind of elevated terms, but people also tend to think of it as a tumor. You just now made a reference to liver tumors. Can you tell us on a really basic level, what is liver cancer?
Yeah, it's a good question. It's good to kind of talk about the basics at the start here. So, liver cancer, there's various types of liver cancer that we see in clinic. And, a cancer is just an abnormal growth of previously normal cells. And, it happens at multiple places in the body. And in the liver, there's two main types of liver cancers that we see in the clinics. One is going to be from the liver cells themselves, called hepatocytes. They're the cells that do all the functions that the liver do. And that's called hepatocellular carcinoma. That's the most common type of primary liver cancer. And the other type is a cancer of the bile duct cells. There's a lining of the bile ducts that, put bile into your small bowel. Your liver makes bile, and then the bile helps digest fats and other things in your intestinal tract. And the lining of those bile ducts can become cancerous, and that type of cancer is called cholangiocarcinoma. And so these are abnormal growths of these previously normal cells that cause problems that, we typically see. Now, the other question is, who's at risk of developing liver cancer? And I think you mentioned a couple of things like cirrhosis and fibrosis. For the patients with hepatocellular carcinoma, which is the cancer of the liver cells, most of the patients in the US that develop liver cancer from that type of cancer have underlying cirrhosis of the liver. And cirrhosis is just scar tissue that forms from chronic injury in the liver. Patients with cholangiocarcinoma, there's an increased risk with underlying cirrhosis as well. There are other conditions like autoimmune conditions of the bile ducts, something called primary sclerosing cholangitis, that can lead to cholangiocarcinoma, but also cholangiocarcinoma can happen randomly and for reasons we don't fully understand. So those are the two main types of primary liver cancer that we see. Of course, there's other things like other cancers that metastasize to the liver, but those are secondary liver cancers, and that's kind of a different conversation.
Yeah, and I'll have to say I appreciate your spelling this out. I think so often in the liver space we get caught up in the acronyms of HCC and PSC and whatnot, and having the distinctions about what they actually are really helpful. After identifying this, I want to go from kind of micro to macro. What are the trends that we're seeing right now in liver cancer? You talk about the patients with cirrhosis, or you talk about with PSC, with bile duct issues. Kind of, I don't want to say lesser so, but stuff that is metastasized. That's a little bit of a different ball game as well. Are there trends that we're seeing in this? Is cirrhosis on the rise to causing liver cancer? Is there just kind of a continuing concern? Where do you see the trends going in liver cancer right now?
Yeah, it's a great question. So there's a few things that are happening all at once. So, for years, the primary driver of liver cancer in the U.S. was hepatitis C virus, and that was there was a kind of a generational impact of hepatitis C due to various issues happening at once, where there was increased use of IV drug use, and there was increased or there was lack of screening of the blood supply. So there's a generation of baby boomers that were infected with hepatitis C for years. And hepatitis C is a virus that affects the liver, and it can take 20, 30, 40 years to cause any problems, any significant scar tissue, and eventually lead to liver cancer. And so over the last 20 years, we saw a precipitous increase in the rate of liver cancers, probably because of the generational effects of hepatitis C virus. Now, a couple of things have happened. One is that there was less transmission of hepatitis C after the baby boomer generation because of changes in behaviors and screening of the blood supply and things like that have happened. Another is that we've gotten treatments for hepatitis C. So now if somebody gets infected with hepatitis C, we have effective treatments that can cure them. So that has really dropped the rate of development of significant liver-related complications from hepatitis C over time. And one of those complications is, of course, liver cancer. Now, what we've seen in parallel is increases in metabolic liver diseases causing cirrhosis and liver cancer. And those are, we call metabolic dysfunction associated steatotic liver disease, which is formerly known as, kind of non-alcoholic steatohepatitis or non-alcoholic fatty liver disease. The names have been changed around to reduce stigma associated with them. But, essentially this is associated with obesity and diabetes, where fat cells infiltrate into the liver and cause an inflammatory reaction. And over time, that inflammation, just like any other inflammatory disease of the liver, can cause fibrosis and development of cirrhosis and liver cancer. What we've also seen in some patients with fatty liver disease is development of liver cancer without the presence of cirrhosis. And for reasons we don't fully understand, this is something we're increasingly seeing. So I think when we talk about trends, right, we have seen probably a plateauing or maybe steady mild drop in the incidence of primary liver cancer in the U.S. But there is this whole population with this MASL, this metabolic associated steatotic liver disease that is developing, that has an ongoing risk for development of liver-related complications and HCC. So I think there's been a very steady stream of these patients, and that's kind of accounting for the trends that we're seeing. In terms of the PSC story, it's a relatively rare disorder, this autoimmune disease of the bile ducts that leads to cholangiocarcinoma. And so that's been kind of a steady stream. We are, seeing slight blips, increases in the incidence of cholangiocarcinoma that is happening kind of countrywide, which we don't fully understand, but that is still, a small proportion of the primary liver cancers that we see overall.
It's so interesting. I mean, let me pick out one thing that you said there, and that was that you do see instances of liver cancer without cirrhosis, kind of skipping over the cirrhosis stage in this. And so that automatically, in my mind, makes me think about, wow, how do you determine who's most at risk then for this? Because, we deal with generalities to try to hit the wide swath of people and whatnot. And thinking about that, we don't want the exception to become the rule, but we do want to be inclusive of anybody that may be at risk in this. How would you determine kind of who's at risk here?
Yeah, I think that's a really great question. Something that the field is really struggling to
Yeah.
deal with right now, because we talk about who should be screened for liver cancer. I think this is a big question that's popped up, and the traditional guidelines or anybody with cirrhosis should be screened for liver cancer, and there are certain populations that have chronic hepatitis B without cirrhosis that should undergo screening. Now, most of these patients are, were are contracted the hepatitis B through birth, which is a major way to contract hepatitis B. And a lot of patients, for example, in China, that's why hepatitis B is somewhat endemic, is that patients get it at birth, they get it from their mother, and they have it for the rest of their life because it's a DNA virus. It's very difficult to get rid of, or it's impossible to get rid of completely. And so patients with chronic hepatitis B who've had it for the rest of for their lives, there's a recommendation to screen them because after a certain age, they become high enough risk to do screening. Now, when we talk about the fatty liver population, I mentioned that we do see patients that have liver cancer with MASLs without cirrhosis, but that's a very small incidence, right? We talk about, in the US, there may be, 70 to 100 million adults with some level of MASLD. And the question is, how do you risk stratify that group if they don't have cirrhosis to developmental liver cancer? And that's something we don't really have the answer to. Because if we screened everyone, the incidence of the cancer is so low that we get more false positives than true positives, cause a lot of downstream effects, patient anxiety, those sorts of things. And the system would be overwhelmed because we have so many patients. And so, the question is, how do we risk stratify them? That's an area of increasing research and investigation that our group and others are involved in. And so I don't have the answer for you for that. But for right now, what do our guidelines say? Our guidelines say that if you have cirrhosis, you should be screened for liver cancer. If you have PSC, you should be screened for cholangiocarcinoma. And if you have chronic hepatitis B without cirrhosis and fall into certain demographic groups, you should be screened for liver cancer. And that's kind of the extent of where the evidence is right now.
Yeah, it's so interesting because I mean that has such implications down the line for, payers, for reimbursement, for getting your even the diagnostic stuff covered and whatnot. Is it becomes so complicated so quickly in this. The mention of false positives in this kind of begs my next question on this, though. I mean, I think everybody's always concerned with false positives. I feel like they became a more prominent part of the national conversation during COVID and the pandemic and whatnot. Let's get into the mechanics of this a little bit for the next part of the conversation. So, if I'm someone that kind of, for whatever reason, is at risk for liver cancer, talk me through that process. Talk me about kind of, as I come in to see my physician, what questions should I be asking, and then what should I expect in terms of a liver cancer screening? What tools are you going to use? Et cetera, et cetera, et cetera. So what am I asking to kind of get more information, and then what are the next steps that you would take?
Yeah, I mean, I think a new diagnosis of cirrhosis can be really scary for patients because there's a lot of stuff that's out there, and I think the messages are that cirrhosis is a disorder that requires management and requires kind of ongoing care. So if someone's been diagnosed with cirrhosis, you should be seen regularly for that diagnosis because you do require monitoring. People are diagnosed at different stages of cirrhosis. So most people with cirrhosis in the United States, there's about 2 million adults, we think, have cirrhosis in the United States. Most people are what we call compensated, which means they don't have any symptoms. They didn't know if you didn't tell them they had cirrhosis, most people wouldn't know. And the question is, how do you find those people? That's a whole, again, another, maybe another webinar or something to discuss that. But those are, that's always a challenge. But once you do identify cirrhosis, the stage that you're identified dictates what should happen. If patients are decompensated, which means they have complications of cirrhosis, they have, fluid in the belly, other things that have happened, can happen, intestinal bleeding, confusion, they should really be considered for liver transplantation because that's the cure besides management of the complications. Now, if somebody is compensated, of course, they don't necessarily need a liver transplant. They can be managed, but they do need to be monitored. And there's disease-specific preventative care that we provide to patients with cirrhosis. We talk about preventative care in general, doing your cancer screening, doing all that sort of thing. But cirrhosis has its own kind of cadre of things that should be completed on a regular basis, and your provider should be part of that. And one of those things is liver cancer screening, as I'd mentioned. And so current guidelines recommend an ultrasound and a serum blood test called the alpha-fetoprotein every 6 months. The ultrasound is of the liver, and that should be done, again, on a semi-annual basis in patients with cirrhosis. Now, ultrasound is not perfect. It's an imaging test. The quality of it varies depending on where you go and how experienced people are and how well they can see what's going on in the liver. The visualization is really important. And so when we talk about false positives and false negatives, that's where we run into issues sometimes, is with the ultrasound and how it's conducted. False positives are common. We had done a study several years ago looking at the University of Michigan, the rate of false positives on ultrasounds over a couple-year period in about 1,000 patients who have undergone screening. And we found about a quarter of patients had a false positive at some point in that continuum. So it happens, and it can lead to a lot of consternation. But I often counsel patients that if we find something on ultrasound, that we need to do a diagnostic test to figure this out, and I would not worry until we have that test done. And that's typically an MRI of the liver or a CT scan of the liver that's protocoled for the liver. And so that's how we deal with this. Now, if somebody has an ultrasound and the visualization is poor, I mentioned that visualization is something that's important, and the radiologist should be denoting how well they can see the liver, and there's a way to do that in a standard way. If the visualization is poor, then oftentimes I'll just recommend an MRI intermittently just to make sure we're not missing anything. And the last part I'll say is that alpha-fetoprotein is important, that serum test. It can help tell if there's a cancer, and it is responsible for the detection of a small proportion of liver cancers, which is why it's an add-on test to the ultrasound to increase the sensitivity of the ultrasound itself.
Again, interesting. I mean, this notion of the false positives comes up. That's a lot of a pretty big number in terms of that. And I'm curious. To me, this cites the importance of patients being able to ask important and correct questions and being able to have the right information going in with this. So if I'm in a liver cancer screening and I see something that's or it's interpreted as there's something concerning that has popped up, and I don't know what something concerning is. Maybe it's like you said, it's a, obscured image. Maybe it's an actual tumor of some sort, something that is concerning that's comes up. Talk me through kind of what your next steps are. What are the tools that you used? Kind of what should patients know about follow-up in these instances?
Yeah, I mean, I think it's important to follow those up. I think it's the idea of this is a screening test. It's not a diagnostic test. So screening tests sometimes give us a signal, but not necessarily the answer. So it's important to follow that up and be proactive about that. Anytime any patient enters in a screening program, I always talk about the possibility of false positives, false negatives. No test is perfect. And certainly we've seen that with ultrasound. If somebody has something on ultrasound, the next step is for me to talk to them, talk about what this means and what we think. And then the next step would be to get an MRI of the liver at our center. Some centers use CT, some use MRI. It just depends on what your center is most comfortable with. But then getting that MRI is really important. Interpreting it, making sure that you understand what this abnormality is. Oftentimes, we'll present it at our liver tumor board to talk about what is this diagnostically. Is this a liver cancer? Is this something else? Do we need to treat it? Do we need to biopsy it? And then circling back with the patient, communicating clearly with them what the plan is from here and how we're going to deal with it is typically my approach.
Okay, you've mentioned something there that I think patients may not be aware of as much in their conversations with their physicians. Liver tumor board. Tell me about that. What is a liver tumor board? What is the role of a liver tumor board in terms of kind of like the patient pathway through this?
Yeah. Most big centers and even smaller community settings have developed these multidisciplinary liver tumor boards sometimes for liver cancers, which kind of at high volume centers is very liver specific. Sometimes it's a GI oncology liver tumor board, but typically these are meetings. And at our center, we have it weekly, where we have all the folks that are involved in our tumor program, from hepatology, medical oncology, radiation oncology, interventional oncology, or interventional radiology, excuse me, and cross-sectional radiology. So our nurses are a part of this as well, in order to review images and laboratory and clinical scenarios of patients who either have diagnostic dilemmas, they have something, we're not exactly sure what it is, they have cancers that need treatment planning, and or they are patients that we need to review the anatomy for resection or something like that. So these are meetings that we have really to talk about the patient in a group setting and come up with the best recommended plan or the menu of options that a patient may have for treatment. Typically, after a tumor board, I talk to the patient, and then we discuss what the discussion was, and we go with the plan. On rare occasions, we've had patients who are really engaged that want to be present for their tumor board, and we do these over Zoom now. And they kind of log in and they are part of the conversation as well. So these are different options that we have these days, and that's how the liver tumor board kind of helps come up with treatment planning, both for the initial treatment and subsequent treatment for patients in our system.
Yeah, I love that sort of patient engagement in the board. I mean, even if not, part of the conversation, to at least even bear witness and to be able to raise questions later on about what does this mean or how does this impact, the question that this person raised or that person raised. That's really amazing. Now, two last questions for you here, and I really do appreciate your time today. So if a patient shows up and are there common reasons that you're aware of that they don't get screened? I mean, even before the diagnostic level, or by the time that you see them, have they already moved past that stage?
Yeah.
What should patients, how would you encourage them to take this next step?
Well, I think we see a few different issues that have popped up. So one is that lack of recognition of liver disease and cirrhosis. That is a very common thing. A lot of my patients are diagnosed with liver cancer and cirrhosis at the same time, and they had no idea they had any of those. There's guidelines from the American Diabetic Association that have recently come out to do screening in patients with with diabetes for advanced fibrosis and cirrhosis. And so these guidelines are coming down the road, or more patients are being identified. There was universal screening recommended by the CDC for hepatitis C virus, for example. So these are things that, population level screening, can we do a better job with that? And certainly there are ways to do that. The second issue is lack of knowledge about actual screening for liver cancer, because the level of evidence for screening is based upon observational studies, which means there's not been a really big randomized trial for screening that's out there. So this doesn't make it into the United States Preventative Task Force screening guidelines like breast cancer screening does or colon cancer screening does. And so the reason, so that, that limitation has prevented folks like some primary care providers, some even some gastroenterology providers from really understanding that screening can be beneficial and should be recommended. It's not really on their radar screen. And so, these are the issues that we see in the community of why patients aren't offered screening. And of course, screening is pretty intensive. This isn't once every 5 to 10 years. This is every 6 months. So, patients can also miss screening or, it's an imaging test, et cetera. Logistically may be difficult to get, maybe expensive, copays. These are all barriers that we've seen and described to screening that have been out there. And certainly we need better mechanisms to screen patients for liver cancer.
Yeah, I mean, I would add, if you're in a rural setting, there's going to be barriers there as well. And, and I think, frankly, some people don't even say cancer anymore. They just talk about the C word in that way. It's a very scary thing for people to engage. I've got, probably 7 to 8, a dozen sort of other areas where I feel like I could do deep dives with you on this. And so this is really great information. I really appreciate the time with you and sharing like this. Let's sum up the conversation today. So, traditionally we talk about takeaways, about things to remember on this sort of stuff. If you are talking to random person on the street, and you want to, encourage them towards liver cancer screening, want them to protect their liver health, want them to have one thing kind of to take away from this, what's the sales pitch? What's the thing that you would want listeners to remember about liver cancer, especially screening and protecting their liver health?
Yeah, I mean, I think I think you can think of this as a giant filter, right? Or a giant funnel. There's a big population of patients out there who are at risk of liver disease. There's a group that have liver disease that need to be discovered, and understanding an individual's liver disease risk is important. Once you do have liver disease, screening, we believe, is beneficial in patients who are at risk, because early detection of liver cancer gives people so many more options for treatment than later detection, and survival is much better. So, that's kind of where we're at, in the liver cancer screening world, is that recognizing risk and then applying the tools that we currently have while we're developing new ones is really the goal of what we've been trying to do.
Awesome. Well, thank you for everything you do on behalf of patients. I know you've been seeing patients today, so thank you on their behalf. Thank you on behalf of future patients as well. And we really appreciate your time, Dr. Parikh. Hope we're able to have you back on the show sometime to do a deeper dive on any number of the topics that we just kind of skimmed over the cross of. So thank you for helping us and for being a part of October's for Livers here at GLI.
Yeah, anytime. Thank you for having me. It's a great conversation.
All right. Wow. What a great conversation with Dr. Parikh from up in Michigan. Joining us for kind of our post-conversation breakdown, our usual great producer extraordinaire, Lily Bainig, and joining us extra special, our director of liver cancers, Sarah Maines from the great state of Minnesota. Thanks, guys. That was really a cool conversation, I thought, with Dr. Parikh. I mean, it's so cool to be able to find practitioners and researchers that are able to kind of take that step into translational science, if you will, to be able to break down these these things that we think we know what they are, but they're actually convoluted, and put them into simple terms. I mean, something even as simple as what is liver cancer, I thought, was really a great breakdown of kind of the difference between that and kind of how some other cancers evolve, and he talked about, tumors versus whether something's metastasized. Sarah, let me go to you first in our post game here. Having heard the conversation with Dr. Parikh, what would you consider priorities now going forward? We've heard kind of liver cancer 101. As we attempt to address this for patients, what would you consider priorities going forward?
Absolutely. And I think Dr. Parikh, he just did such a good job also talking about just the basics on what does that mean and putting it into everyday terms that even for us who we work in liver health, I feel like for me at times there were some aha moments and I'm like, that's exactly it. It's such a good way to position. But when I look at, where are we going? And yes, this is October is for livers. This is our Liver Cancer Awareness Month. And that also means that it's Liver Health Awareness Month. And I see a lot about screening being a priority. I have reframed a lot of what I'm doing in the liver cancers department at GLI, talking about the education, prevention, detection, early detection, screening, and then also how that flows into treatment, survivorship, and still end of life needs with the morbidity being as high as it is still. And when I think about emphasizing screening, I think it's that critical bridge between prevention and survival. So here we're making really incredible process and progress in liver disease, but liver cancer rates are still rising and people are getting diagnosed too late. So what's the responsibility there? What do we need to do? So I think with screening allowing us to identify diseases earlier, we need to intervene sooner. That's going to help us save lives. So I think that focus, we share responsibility in creating what that looks like. And, we want equitable access. Like, what does that entire liver health continuum look like? Access to screening. There's still so much done, limited access, inconsistent clinical practices, understanding, what does that look like and how does advocacy come in? So I'm so hopeful that, we can bring more equitable access and education to screening so more early stage liver cancer diagnosis can happen.
Yeah, that's interesting. I mean, you're raising a couple of different interesting issues in there as well, and I'm going to kind of pinpoint this notion of equitable access because I think that tracks backwards, if you will. When we talk about, you mentioned that it's, we have it as October for Liver. Some people are beginning to acknowledge this as Liver Health Awareness Month. That's kind of a little bit of a false dichotomy to me, if you will, because so many liver diseases do result that pathway is towards liver cancer in this. But when we talk about equitable access to screening, we're kind of beginning to get into the public health kind of realm on this. And of course, that means, Lily, I'm going to bring you into the conversation on this for a public health kind of perspective on this. How do you see the priorities or the barriers, if you will, to screening, to early diagnosis? Is this merely about people being scared to know that it's cancer, or do you think that from Dr. Parikh's conversation, we talked about a bunch of different liver diseases out there. What are kind of your perspectives on that?
Yeah, I think that's like a three-part question, but I want to pull in something that Dr. Parikh said that I think we don't think about enough and is often not understood well. He said screening tests are different than diagnostic tests. And I think that really understanding that helps you understand the big public health picture that, and this is true not just in liver cancer, it's true in many other cancers as well. A positive screening test just means that it's time to look for more and is not as scary, but also not as not as scary, but also not as precise as the actual diagnostic that you'd look at. But when you're looking at the population of hundreds of thousands, millions of people, it's extremely helpful to be able to look at the people who are at the most risk and who have the likelihood of that test being worthwhile. That's important because these tests have to be done every several years. It's hard to get there. And I think that's where then the access piece comes in. Are the tests available at every facility? Many people, especially in rural areas, are only going to their primary care facility. It might be hard to get to the specialized places. So that's where we can use a lot of these non-invasives that use technologies and blood draws and things like that people are already doing. To go from this huge population where everyone has a liver, everyone could have liver dysfunction and could develop liver disease to who is most likely. So we're catching things early. And so that first tool is really less of a clinical tool and more of a public health tool. And hopefully, because it's a very real fear that people have, of learning about cancer. Hopefully that brings a little bit of peace of mind.
Yeah, it really is kind of I love the distinction that he made between screening and diagnosis. And, so often in the liver community, I think we get caught up in the diagnostic part, that we've got to diagnose, which is valid. And there is a very real need for better and more equitable sort of diagnosis throughout. That's the whole conversation about non-invasive diagnostics. It's literally diagnostics. But it's really interesting to think about this notion of being able to have more equitable access to screening, because ultimately that's something that I think that, especially from a public health perspective, we can wrap our heads around a little bit more so. It doesn't feel as invasive. It feels like you're kind of just checking things out. I remember several years ago when I was working more in fatty liver disease, we changed kind of some of the guidelines to say that previously, they had presumed that if you had diabetes, you should be kind of tested and screened for NASH at the time, or what's known as MASH now. And then they changed that because so many of the diagnostics were coming back and saying, no, if you have diabetes, you should actually be tested for MASH for the more advanced stage, as opposed to just being screened for the early stage. And that really was a big moment in kind of changing how practitioners engaged patients. I hate to sound like a business book saying, but does it scale? But I think that really is kind of the issue when we come to these sort of things. Sarah, I'm going to leave the last word with you on this. And, you've been working in this field for quite a long time, and the victories are tough to come by in cancer writ large, if you will. And in the midst of it all, let's think about something 10 years, 15 years down the road where we have accomplished something good. What is the thing that gives you optimism on reaching that thing right now?
Well, and I think that the underlining word to optimism, especially in oncology care, patients and multidisciplinary care team, is hope. And what does that mean? Hope, it's at the root of the word that we use a lot with our patients and caregivers. And there's so many scientific advances that are happening. Even in the last couple of years, how much the liver field and liver cancer has grown. And from an oncology standpoint, we think about immunotherapy, combination treatments, precision medicine, all of those things, that's improving survival. Beyond the science, what really gives me hope, though, and it's also just like that root of what GLI does, is the people. Like, it's the survivors who are speaking out and talking. It's the caregivers who are helping change the systems, helping their loved ones. But it's also the providers on how they're bringing liver health into those everyday care conversations. This is where we're going to see that long-term impact. That gives me hope. I know, talking with providers and patients and all of you as my colleagues, I think that that's so important. Even in the last few years, at times, I think liver cancer has had a tendency to kind of be that forgotten cancer. It doesn't get talked about a lot, but it's the third or fourth highest cancer incidence that we see. The death toll is very, very high, but that's changing. And so when I think about all of these voices from patients, caregivers, healthcare providers, all of those collaborations, and even all of those early diagnoses, that's what builds hope for what's ahead and fills me with a lot of pride in what we're doing at Global Liver Institute.
I'm Jeff McIntyre, and on behalf of producer extraordinaire Lily Bainig and our liver cancer colleague Sarah Maines and the whole team at Global Liver Institute, we'll see you next time. Thanks, Sharon.